Welcome to the deep dive. Today we're tackling avascular necrosis. You might also know it as osteonecrosis or bone infarction.
That's right.
Think of this as your sort of focused guide. We want to give you the absolute essentials you need for revision.
Exactly. Our mission is just that. Arm you with the key knowledge on AVN. It's important stuff because, well, it can hit various bones. Hip, knee, shoulder, ankle are common.
And the symptoms can be tricky. Sometimes slow, sometimes sudden.
Precisely. It varies quite a bit.
Okay, so let's nail down the definition. What exactly is AVN?
Fundamentally, it's when bone tissue dies because it's not getting enough blood. Simple as that, really.
And clinically, that often pops up after, say, high-dose steroids or maybe a bad hip fracture.
Yeah, exactly. Those are key scenarios where you'd think about disrupted blood flow leading to this. Definitely high yield for revision.
Got it. So what are the main culprits? What actually causes this lack of blood supply?
Okay, so there are several key causes. We can actually use a mnemonic to help remember them. To catch a bright rainbow under enormous iridescence. A bit of a mouthful, maybe, but memorable.
Huh. Okay, let's break that down then. T?
T is for trauma or a significant injury to the bone. Pretty straightforward.
Right, C.
C is corticosteroids. This is a big one, especially, prolonged use at high doses. It seems to be dose dependent.
Okay.
A stands for alcohol, specifically excessive intake. B is for blood clotting disorders. Things that make the blood more likely to clot and block those small vessels. R is radiation therapy. That can damage blood vessels. U covers underlying diseases. Think sickle cell disease, where the cells physically block vessels, but also conditions like lupus or even HIV. E is for excessive pressure within the bone. You might see this in Goucher's disease or SCFE, slipped capital femoral epiphysis in kids.
Okay, and finally I.
I is idiopathic, which just means, well, sometimes we just don't know the cause.
Right, unknown. So the risk factors, I imagine they overlap heavily with these causes.
They really do. So yeah, history of bone trauma, the long-term high-dose steroids, heavy alcohol use, those underlying conditions like sickle cell, radiation. And sometimes there's a genetic link too.
Makes sense. Now, pathologically, what's actually happening inside the bone?
So the core mechanism is that impaired blood supply. The bone cells, the osteocytes, they die off. And without those living cells maintaining the structure...
It weakens.
Exactly. It weakens, and over time, it can actually collapse under stress. Vascular disruption is key, but also altered bone metabolism plays a part.
So if someone comes in with joint pain, AVN is on the list, but what else are we thinking about? The differential diagnosis?
Good question. You definitely need to rule out other common things. Osteoarthritis is a big one. Rheumatoid arthritis, too.
Okay.
Also, bone tumors need to exclude malignancy, infection like osteomyelitis, and sometimes stress fractures can present similarly. Imaging becomes really key to tell them apart.
And how common is this condition? What's the epidemiology look like?
It varies quite a bit depending on which bone is affected and what the cause is. Generally, it's most often seen in adults, maybe aged 30 to 60.
Okay.
And yeah, prevalence differs a bit between different populations.
Clinically, what are the typical signs? What does the patient complain of?
Pain is usually the main thing. Joint pain, often related to activity initially, but can become constant.
Right.
They might also have a limited range of motion, some stiffness, and, gradually lose function in that joint. But importantly, early on, symptoms can be really mild or even completely absent.
Which makes diagnosis tricky sometimes, I guess. So how do we investigate?
Diagnosis starts with a good history and physical exam, of course, but imaging is absolutely crucial. X-rays are usually the first step, but they can be normal early on.
So what's better for early detection?
MRI. MRI is the gold standard, really. It can pick up changes much earlier than an X-ray. CT scans can also be useful, maybe more for assessing the extent of bone collapse later on.
And blood tests.
Yeah, blood tests might be done, but more to look for those underlying causes, like clotting disorders or markers of inflammation.
Okay, so once you have the diagnosis, what's the plan? How do we manage AVN?
The main goals are, well, pain relief, trying to improve or maintain joint function, and ideally, stopping the disease from getting worse.
And how do we do that?
We often start conservative. So pain meds, physical therapy to maintain range of motion and strength, maybe using crutches or a cane to reduce weight bearing, and lifestyle changes like limiting alcohol.
But if that's not enough?
Then we look at surgery. Options range from things like core decompression drilling into the bone to relieve pressure and encourage blood flow to bone grafting.
Okay.
There are also joint preserving procedures trying to save the original joint, but In advanced cases, especially with collapse, joint replacement surgery often becomes necessary.
What's the long-term outlook, the prognosis?
It really depends. Depends on the stage when it's diagnosed. Which bone is affected hip tends to be more problematic than, say, the shoulder sometimes. The underlying cause matters too, and the patient's overall health.
So early diagnosis is key.
Absolutely. Earlier treatment generally leads to better outcomes. But it's true that AVN can progress, and yeah, joint replacement might be the end result for many.
And are there specific complications to watch out for?
Yeah, definitely. The bone collapsing can lead to joint deformity. Chronic pain and limited mobility are common. It can also cause secondary osteoarthritis in the joint. And of course, any surgery carries its own risks.
Okay, so wrapping up then. The key takeaway is that AVN is serious bone tissue dying due to lack of blood, needs timely diagnosis and management.
Precisely. Understanding the causes, how it presents, and the investigation steps is crucial for your revision.
Absolutely. So make sure you revisit these notes. Maybe think about how the pathophysiology links to the symptoms and management options. And for more excellent MSRA revision tools,
definitely check out passthemsra.com.
And also freezesra.com for, well, free resources. Both are fantastic places to go.